Morning. Our next speaker is Dr. David Metz. He's the vice chair of NANETS and a gastroenterologist at University of Pennsylvania and co-chair of the neuroendocrine program at the University of Pennsylvania. Dr. Metz.
I told him to tell you guys all that I was a hell of a nice guy, but he elected not to say that. Anyway, it's a pleasure to be here. Thanks, Marianne and Bob, for inviting me. I must tell you that CCAN is now NCAN. I think is a tremendous advance. I came to this business through Zollinger-Ellison syndrome, which is not carcinoid syndrome. And you're absolutely right. I think there's a whole lot of areas in terms of functional neuroendocrine tumors that haven't been addressed in the past. So I'm a gastroenterologist, and I want to focus a fair amount on what we do as GI docs in making these diagnoses and in sort of trying to identify locations and how that impacts on management of patients. And I'm happy to take any other questions that I don't cover today. I've only got an hour and a half to talk, right? Okay, good. Well, moving right ahead, it's difficult to actually see here, so I might just step a little forward. I'm going to be talking about the role of the role of the gastroenterologist in neuroendocrine tumors. Let's just talk about a little bit of epidemiology, although you've heard a lot about this already. So these are the second most prevalent cancers of the GI tract. There are over 100,000 patients living with neuroendocrine tumors in the United States, and the principles of management for NETs are completely different from other standard solid tumors. We'll talk a little bit about this. You've already heard the incidence is increasing. This incidence is not just because of increased diagnosis. It really is because of awareness and the fact that people are becoming more au fait with making the diagnosis. But for other unknown reasons as well, neuroendocrine tumors are certainly on the increase. This is one of Rod Pommier's slides from the North American Neuroendocrine Tumor Society, which I really like because it puts in context how neuroendocrine tumors differ from standard solid malignancies. And on the right-hand side there, you see the usual iceberg type approach where the primary tumor at the base of the pyramid is very big. It then spawns metastases to lymph nodes, which grow, and then they spawn secondary metastases into the liver. Neuroendocrine tumors, however, are on the left-hand side of the slide, and they're very, very different. They're upside-down tumors. You can have a very, very tiny little primary tumor sitting in the duodenum or the pancreas or the small bowel, big, bulky lymphadenopathy, lymph nodes that you can see on CAT scans and MRI scans, and tremendous disease all over the liver. And people will present at times without ever having had anything when they had their primary and their lymph node metastases. And it's only when they get significant metastases in the liver, where all the bulk of the tumor is, that they ultimately come to diagnosis. And I'll talk a little bit about the way people present next. But the important point is that the liver is your target here. And that's why our treatment is so directed against liver disease, because what ultimately I think causes demise of patients is tumor burden growing in the liver. But it's an upside-down presentation, so you can have a tiny little primary there and not find it. And unless you know where you're going and what you're doing in terms of surgical therapies, you need to know to go and find that primary, because if you don't take a primary out, you can do a great debulking operation, but you've still got that source of tumor that's ultimately going to grow. So these are the three presentations of neuroendocrine tumors. Number one, you've heard already, the hormonal syndrome. That requires a good doctor. Dr. Gerstein made a very, very important point there. People walk in with all sort of non-specific vague symptoms, and you're looking for that needle in the haystack. So you really need to be able to put two and two together. The second thing is tumor symptoms, actually from tumor growth. But because of this upside-down growth, by the time you develop tumor symptoms, you're late in the course. And that's unfortunately a real problem. So patients present late with metastases. And the third way we are finding more and more patients now is just an incidental finding. Asymptomatic patients who come for some other reason. Either they can be tiny, tiny little lesions. Somebody comes to me once a week and says, I did a screening colonoscopy on Mrs. Jones, who's 53 years old, and guess what? I found this little tumor sitting in her rectum. What am I going to do about it? That's easy. It's a small, localized, lucky finding. But similarly, you can also fall down the steps and hurt your flank, get a CAT scan looking for broken ribs, and oh my God, you've got tumor all over your liver. And I'm sure there are people in the room that have presented that way as well. So you can also present late, but with significant disease. The really important point is the only way you're going to definitively cure neuroendocrine tumors is if you can cut it all out early on when it's still resectable. So that's the most important target. As soon as we see somebody who has an NET, the aim is to determine is this resectable or not. If it's resectable, go for surgery. Even if it's not resectable, you will go for surgery because most of us are now in the camp that debulking has a tremendous impact in terms of affecting prognosis. So there are obstacles to diagnose neuroendocrine tumors, and they listed on the slide. Rare diseases, you're looking for that needle in the haystack. I see these two-legged zebras behind me. I've been wondering how they're managing to move across the screen here. But zebras, you're looking for an unusual disease, and most docs, if you don't think of it, aren't going to find it. And many patients will say, oh, I've been to 3, 4 different doctors with all these same complaints over 5 years, and nobody ever thought. But that's why, because they're looking for common diseases. And there are many other common diseases that manifest as neuroendocrine tumors. So you're looking for that wolf who's hiding in the sheep's clothing. And I'll show you a couple of examples in my next few slides. Everybody's different. You've heard that already. There are no 2 neuroendocrine tumor patients who are the same. So it's lovely to see all the KR67 numbers and the Kaplan-Meier curves. And this is the statistics. But you're not a statistic. You're Mrs. Smith or Mr. Jones. And everybody's different, and everybody presents differently, and therefore everybody needs some kind of personalized approach. And as was alluded to in the last talk, there is going to be a personalized approach. We just got to keep everybody stable and controlled long enough until we can start working out how to deal with this personalized medicine, which is on the horizon, I really do believe. Often, patients are asymptomatic or vaguely symptomatic for a very, very long time, and so diagnosis is missed. And people don't think about it. So if you come to a doc and you complain of diarrhea, you're going home with a diagnosis of irritable bowel syndrome. You're not going to go home with a diagnosis of carcinoid unless somebody really says, wow, this is interesting. Tell me, do you flush? Oh, okay, you flush as well. Have you ever had any other things? Well, I've been wheezing. Ah, you've got to trigger something for that doc. So it's really a matter of astuteness of your physician. And this is not something that most primary general practitioners are hyper aware of because they just see it rarely. So you really need to be lucky and find the right doc up front. All right, so there are tremendous delays in these diagnoses. So these are some of the data. 90%, this is from the North American Neuroendocrine Tumor Society slide deck. 90% of neuroendocrine tumor patients are misdiagnosed for the wrong disease up front. That's an incredible number. The average time to diagnosis is about 5 to 7 years, whether it's a functional tumor or not. That's amazing. Inflammatory bowel disease or irritable bowel syndrome are the 2 most common misdiagnosed conditions for patients with mid-gut carcinoids. And I'm sure that sitting in the room right now, there are 3 or 4 or 5 people who were told they had irritable bowel syndrome and they were perimenopausal. The diagnosis is not made until metastases develop. And the problem with carcinoid syndrome specifically is if the tumor is in the lymph nodes or in the primary wall of the bowel and produces all these products, they get delivered to the liver and inactivated. So that doesn't get into the general circulation. So it's only by the time you get the liver metastases, in other words, by the time you reach the stage that curability drops off dramatically, that people start saying, oh, I'm flushing, I've got diarrhea. And that's just a terribly unfortunate thing. Now, once in a while, you can be lucky if you develop, for example, a primary carcinoid syndrome producing tumor in the ovary. The venous drainage from the ovary back to the heart bypasses the liver. So occasionally you'll say patients with an ovarian primary or men with testicular primaries that don't need to get liver metastases before they get the syndrome, and they can be picked up early. But that's just a quirk of that particular patient. Neuroendocrine tumors can occur anywhere in the body, anywhere. And so we will all say, oh, this is where they all occur, but I've seen patients with it here and there and other. As I say, no 2 patients are the same. So I'm going to give you a couple of case presentations. And if this is movable, is this going to be, I want to take this off, if that's okay. Then I can see what I'm showing you, if you don't mind. Okay, so case presentation number 1. 47-year-old postmenopausal female, long-standing irritable bowel syndrome with diarrhea, comes to the emergency room complaining of cramping, nausea, vomiting, and she hasn't had a bowel action now for 24 hours. That's a whole new change for her. She's developed an obstruction in the GI tract. Her exam shows that she's a little bit obese, she's in significant distress, she's flushed, she's hypertensive, her blood pressure is high, her heart rate is fast at 108, and the abdomen is distended. She's got no bowel sounds, and she really looks ill to you. She gets an abdominal x-ray, and that shows multiple air fluid levels, meaning the bowels are obstructed, and the fluid is collecting, and the bowel is getting distended, and there's no air in the rectum because she's passed the last bowel action 24 hours ago, and now everything's stopped. A nasogastric tube gets put in to decompress all that fluid sitting in her bowel. You get a whole lot of return, and she feels a whole lot better, except she's still got a bowel obstruction. So she tells you, I've had irritable bowel syndrome when I've had 6 watery bowel movements for many years. I used to use Imodium, but it doesn't work anymore. Now I'm starting to wake up at night from sleep, needing to go to the bathroom. I've had 3 accidents in the last 6 months. I've had abdominal pain that's been progressive and getting worse over the last few years. I've also just started replacement hormone therapy because I've been told I'm menopausal. And nevertheless, here I am in your hospital now, feeling very miserable. I'm sure people in the room can identify with this, right? Okay. Why is this not just irritable bowel syndrome? What else could this patient have? What's the real diagnosis? And that's the clues. Yeah. So there were a bunch of clues there, by the way, that the astute doctor would have thought of. And the example are, she has nocturnal diarrhea. She has been developing pain. This has been going on for many years. She has flushing associated with it. It isn't because she's menopausal, it's flushing. One of the important differences, flushing versus flashing. Postmenopausal flashing is wet. So people who go through menopause and flash have sweating associated. The flushing of the carcinoid syndrome is dry. So, and that's a really, really important clue for a physician to understand. She gives this long history. She's now incontinent. That's not irritable bowel syndrome. She's getting diarrhea at night. That's not irritable bowel syndrome. So there are lots of clues people need to think of. And here are the important symptoms for the carcinoid syndrome: flushing, diarrhea, heart valve lesions late in the course of the disease, cramping abdominal pain, and all the others listed in blue. If you compare the differential diagnosis of the carcinoid syndrome to all these other causes of diarrhea, the most common by far is irritable bowel syndrome, so people get misdiagnosed. Inflammatory bowel disease is what all gastroenterologists tend to look for: Crohn's disease, ulcerative colitis, because they're relatively common. Celiac disease is another common cause of diarrhea. Lactose intolerance is all over the show. And other syndromes that can cause diarrhea, like Zollinger-Ellison syndrome, the VIPoma syndrome, medullary carcinoma of the thyroid, are rare. And so it's very difficult for people to actually cotton onto this persistent diarrhea as a presentation because it's a rare disease. So the diarrhea plus flushing is really what's suggestive. There are a few other unusual things that doctors need to think about. The one I wanted to stress is menopause. The flush is not a dry flush. In your book, I've listed you one of the figures that we've made from a teaching slide kit just to show you that the carcinoid syndrome, compared to its 2 most common mimickers, inflammatory bowel disease and irritable bowel syndrome, there are some important differences. And the most important difference, as I've already mentioned, is this nocturnal diarrhea and the fact that flushing is very common. Okay, now we're going on to another case. That was a small bowel case. Let's now talk about a pancreatic neuroendocrine tumor and how it can present differently from normal. So this is a 46-year-old man, presents with heartburn, abdominal pain, diarrhea over the last 6 months. He's been on a maintenance acid suppressive therapy for 4 years, ever since he had a duodenal ulcer. Duodenal ulcers are very common, or they were, and they're declining, but still very common as a gastroenterologist. The most common causes are non-steroidals, aspirin, Motrin, ibuprofen, or Helicobacter pylori infection, a bacterial infection. But this was excluded when he had his DU, And he also has been avoiding all non-steroidals ever since his last ulcer. So he had an ulcer, he now gets another ulcer 4 years later, right? Mean time to diagnosis, 5 to 7 years. There's no history of suggestive of hereditary associations with neuroendocrine tumors. Physical exam is totally unhelpful in this situation and is normal, but an upper endoscopy shows a duodenal ulcer, thickened gastric folds, he's making gastric juice, he doesn't have H. pylori infection, and a blood test for gastrin is drawn and it's elevated. So, what's this? This is Zollinger-Ellison syndrome, right? This is a gastrinoma, a tumor making gastrin, and it's not just run-of-the-mill ulcer disease. So why isn't this run-of-the-mill ulcer disease? What are the clues? What is the real diagnosis? So gastrinoma, or Zollinger-Ellison syndrome, is what was traditionally called a non-beta islet cell tumor. I've had the ability to look through everybody's slides that you're getting for the rest of the day, and Dr. Odorizia is going to give you a beautiful history, so I'm not going to spoil it up front. But this is a non-beta islet cell tumor. It's a type of tumor in the pancreas that secretes a hormone called gastrin. That gastrin tells the cells in the stomach, make a whole lot of acid. You get overwhelmed with acid, and that gives you severe peptic ulcer disease. These are commonly malignant neuroendocrine tumors, and they come in two varieties, a sporadic type or hereditary form. And that's our job as gastroenterologists to make that distinction, because the management will differ if you have MEN1 or you don't have MEN1. That's the hereditary diseases associated with MEN. Is anybody here from an MEN family and wants me to focus on MEN at all? Okay, it's really more common than one thinks. So multiple endocrine neoplasia type 1, which is a rare hereditary syndrome, is just something people need to think about with all neuroendocrine tumors. Okay, so what's the presentation for ZE as compared to regular ulcer disease? Well, in actual fact, it's very similar. You can present with complications. You often have reflux disease. The clue for the gastroenterologist is if you get duodenal ulcers, think ZE. Gastric ulcers don't have an association. That's just a clue for us as docs. Abdominal pain doesn't occur in everybody. Up to 30% of the time, people with gastrinomas don't even get ulcers. They just get severe diarrhea from all this juice that the stomach's making. And the reason they don't get ulcers is that if it develops slowly enough, the pancreas starts pouring out bicarbonate to balance all that excess acid. Now you've got a flood of acid and a flood of bicarbonate, and you're spending your life running to the bathroom, and you might look like you actually might have carcinoid syndrome, except you don't flush. So there are many different causes for lots of diarrhea. It's a secretory diarrhea, and the clue for when they land up in hospital is if you put a tube down and suck out all the juice, you've gotten rid of all the symptoms, and that's a good way to diagnose ZE actually. Somebody who goes to surgery, has an ulcer removed, they put a nasogastric tube in, and then you can't get the tube out because every time you pull out the tube, they start vomiting. That's a clue for ZE. So the pathophysiology of ZE is as follows. You have these gastrinoma cells that make gastrin. They get in the bloodstream. They go to the stomach. They tell the parietal cells in the stomach, make a lot of acid, make a lot of acid. So you pour all this acid into the lumen of the stomach. You get ulcer disease and diarrhea. And normally, that acid switches off the release of gastrin because it's a controlled hormonal system. However, these tumors, although they do respond to somatostatin, which you all know about, right? Octreotide, somatostatin, which is a paracrine locally acting substance, these cells will respond, but they're out of this regular loop that normally switches off release. So the ZE patient makes gastrin, lots of acid, can't switch the acid off. Normal people who don't have ZE, when they eat and make a lot of acid, their local somatostatin switches off their own gastrin. So it's a permanently switched on system. And as gastroenterologists, we need to make the distinction between people who have high gastrin in the blood, which is appropriate from therapies or atrophy or H. pylori infection, or inappropriate when it's out of control, and the most important one of those is ZE. So the gastroenterologist, the clue for the GI doc is, here's a patient who's got ulcer disease but doesn't have H. pylori and doesn't use NSAIDs. And that is the very, very big clue that GI docs need to think about. Okay, so I've touched a little bit on the two most common functional tumors, the small bowel carcinoid syndrome and the pancreatic neuroendocrine tumor. Just as common as gastronoma is insulinoma, which I'm not going to be talking much about today, just in the interest of time. But the insuloma is another pancreatic neuroendocrine tumor that makes insulin, and it essentially gives insulin shock. So this is a person who's doing fine, except they missed breakfast this morning and they fall down and bump their head because they get dizzy because their blood sugar is too low. And so there's a whole differential diagnosis that we need to go through of people who have low sugars as a production of insulin from these tumors. And pancreatic neuroendocrine tumors make all sorts of exciting products, which is why it's interesting from a pathophysiologic point of view, and if you're astute enough to think about it, to potentially make these diagnoses early. So the glucagonoma syndrome is a tumor that makes glucagon. That's the opposite of the insulin syndrome. The VIPoma syndrome, which has been mentioned already today, vasoactive intestinal polypeptide, is another product that tumors make. It can give overwhelming diarrhea. In fact, the other name for VIPoma is pancreatic cholera because people died from dehydration. And then there are rarer various functional neuroendocrine tumors that are interesting from a physiologic perspective. So with that background, how do you make the diagnosis and then manage patients with these neuroendocrine tumors? Confirm the diagnosis. Most important thing, don't accept any labels people have. Make sure that everything fits. And, you know, Tom, I'm sure would agree, there are many people out there who unfortunately have been labeled incorrectly. Get told they have ZE or gastronoma when in actual fact they don't make any acid and they end up getting the wrong approach and the wrong surgery for it. Same thing will happen carcinoid syndrome. So confirm the diagnosis. Then make the patient feel better if they have a hormonal syndrome. You can switch off the hormonal products with biotherapies. You've heard about octreotide and lanreotide. Then stage the patient. How extensive is this disease? Is it resectable? Is it curable? Is it debulkable? Which parts of the body are being affected? Where should I be addressing my therapy? Surgery, surgery, surgery. I'm a big fan of surgery. If possible for cure, it's a no-brainer. That would be your best option as soon as you can. Even if not, I'm a great fan of debulking surgery. I think it resets the clock, decreases the bulk of tumor that you're going to be addressing going forward. Control tumor growth. You've heard a little bit about octreotide and lanreotide and seen some of those data. Great fan of it. Relatively well-tolerated medicine. Does great. Doesn't hurt. No-brainer for me. And then the management diverges because it's multidisciplinary and it involves lots of different people. Medical specialists, GI, endocrinology, oncology, surgery, radiology approaches with chemoembolization, PRRT, which you've heard about, which I'm a great fan of as well. So that is when you then need a multidisciplinary board to come together to provide the best therapy for patients. You've already heard about somatostatin analogs. For ZE specifically, you can do great with acid-secreting inhibition. Insulinomas, just by the way, are an unusual presentation. For some reason, they're less oftenly malignant, but when they are, everolimus is a specifically good drug. That's the mTOR inhibitor you heard about earlier. For some reason, has great ability to control sugar. You've seen this already. I'm not going to bore you guys with too much repetition, although it's good to hear it again. The more you hear it, I think the easier it gets in. But somatostatin itself is a great therapy, and Dr. Odorizio is an expert on this. He'll tell you about the olden days when you used to have to put up a continuous infusion because somatostatin works fine, except it's not a hormone. It actually works locally. So to keep it going long enough, you have to infuse it persistently. And it's hard to run around with an intravenous pole, right? So octreotide is really just a slight modification on the business side here of somatostatin. So the receptor binding side, those 4 amino acids are the same, but beyond that, they've slightly modified so that the body can't inactivate it, and it has a longer half-life. It sits around for longer, and therefore can be given Q8 hourly, or every 8 hours, or 3 times a day. And then in the long-acting preparations like lanreotide or sandostatin LAR, with 1 injection once a month. But the same part of the drug is binding. So I don't see any major significant differences. They're the drugs of choice for syndrome management and FDA approved for many of them, but not for all. And their role in tumor stabilization is now firmly established. Let me tell you, 5 years ago, we used to have a tremendously hard time getting approvals for somatostatin analogs because there was no data out there. So then came the PROMID trial, which you saw, which was limited to alimentary tract tumors, and now more recently the Clarinet trial, which was for the lanreotide, which include PNETs. And I think everybody in the business now agrees somatostatin analogs control tumor progression. So they should be on board almost every patient. So you've now controlled the hormones. You've got somatostatin on board and you've got your patient potentially stabilized. Now you've got to decide how extensive is this disease? How am I going to intervene? So you're going to stage the disease with endoscopy or with imaging. Imaging is extremely important. Cross-sectional studies, CT, MRI, as well as octria scanning, MRBG scanning, and the future of gallium scanning and PET scanning, and you're going to hear all about those. I'm not focusing on them at all today. I'm happy to take any questions on the other experts here who know more about it than me. But I don't want you to suggest on the basis of my talk that cross-sectional imaging isn't important. It is absolutely essential. But as I was asked to talk about GI things, so I'm going to focus a little bit on endoscopy and colonoscopy, which is optical endoscopy. Capsule endoscopy is the endoscope you can swallow. It's a camera and see where it goes. Deep enteroscopy are new fancy tools that we have. There's no part of the GI tract we can't see anymore, which is quite amazing. I'll show you the spiral, single and double balloon endoscopes. And endosonography or endoscopic ultrasound, very, very important, especially in the pancreas. So, endoscopy, gapnecks, as you've already heard, are the overwhelming majority of primaries. With modern techniques, we can now see everywhere in the GI tract and its appendages. And by the way, just because I love telling the pulmonologists this, there aren't any in the room today. No one's going to shout back at me. But the lungs actually, embryologically, are an offshoot of the GI tract. We own that too. All right. So newer techniques also now allow us to biopsy in the deep small bowel, which we weren't able to do in the old days. So in the olden days, if you found a lump or bump in the small bowel, the only way you could find out what it was if you took a patient to surgery. Now you can get there with a double balloon, and I'll show you that. It's very exciting stuff. Okay, so we've gone through all the various techniques here. I don't want to repeat you, but the advantages of this is biopsy and localization to guide therapy. I'm not saying every patient needs all of these. And it really is a personalized, individualized approach. I'm going to now take you on a little tour through the GI tract. We'll start off with the stomach. The upper endoscopy allows you to look at carcinoid tumors or neuroendocrine tumors in the GI tract, and especially in the stomach, and type them as type 1, type 2, and type 3. This is essential. Type 1 gastric carcinoids are relatively benign, have a low malignancy rate, have a low risk for patients. And if you have a type 1, you have a party and you relax and you don't get too overwhelmed and you don't let people operate on you too soon. If you have a type 2 gastric carcinoid, that's always associated with multiple endocrine neoplasia type 1 and Zollinger-Ellison syndrome. It's a unique little small group and they need specialized individual management. And what you're worried about is a type 3 carcinoid. And a type 3 carcinoid arises from different cells in the walls of the stomach and is a highly malignant, very scary carcinoid neuroendocrine tumor. So we can tell the difference as at endoscopy very easily by sucking some juice, checking the acid level, and correlating that with a gastrin measurement. Also, as far as gastric carcinoids are concerned, if they're large, you can take them out endoscopically with a technique we call EMR, endoscopic mucosal resection. So you put an ultrasound machine down, you shine it through the wall of the tumor, you show that it hasn't invaded through the wall, and then after you've done that, you inject underneath it with some saline, you lift it off the muscle, you put a lasso around it, and you cauterize it out. So if you find big gastric carcinoids, you can take them out without taking the patient to an operation. And this is my management algorithm for type 1, type 2, type 3 gastrics. You can see gastric pH and a fasting gastrin. That will tell you is it a type 1, a type 2, type 3. If the pH is high, you don't make acid, you have a type 1, it's associated with atrophy, and the risk there is gastric cancer, which is very rare in these patients. So I individualize therapy, but I don't do anything harmful. The type 2, which is a very rare condition, is associated with Zollinger-Ellison syndrome. They make acid and have a high gastrin, and there you're worrying about all the diseases associated with multiple endocrine neoplasia. Type 3, you have a normal pH and a normal gastrin. So the tumor, the carcinoid, is not a gastrin-responsive tumor. It's from a different cell type. It's sporadic, out of the blue. You must get an endoscopic ultrasound there, because if you can catch it very early, you can potentially cure it. But that's the scary one that I rarely send people to the operating room for. And here's some examples. These are type 1 carcinoids. These are type 1 carcinoids, and these are type 1 carcinoids. So you can't tell the difference at endoscopy what they actually look like. It's the biopsy and the gastrin and the pH that's going to make the difference for you. Here is type 2 carcinoids, and this is an octria scan in a patient who had Zollinger-Ellison syndrome and a positive duodenal lesion over there. This hot spot were these two lesions. They were big. We took them off, and the hot spot went away. So MEN patients can get various tumors in various places. You've got to work out which of the tumors are the ones that are worrisome and which are the tumors that aren't. And this is an example of a type 3 carcinoid. The video isn't going to play, not really important, but it's big, it's in the stomach, it's got central depression, it's getting necrosis in the middle, it's falling apart, it's outgrowing its blood supply, it's a malignancy, it's dangerous, it needs to come out. This patient we sent for surgery, total gastrectomy. Let's move down to the duodenum. Duodenal carcinoids can be multiple or single. When they're multiple, you've got to think of hereditary diseases like MEN1. If they're isolated, you can think of going for surgery. And if they're amenable under endoscopic ultrasound, in other words, if they haven't invaded the wall, you can actually snare those off and save the patient's surgery. If you do send these patients to surgery, it's essential that the surgeon knows what they're doing. They've got to be a good surgeon. They've got to shine a light through the duodenum in the operating room. They've got to open the duodenum. They've got to look at the duodenum with their hands, and they've got to feel the duodenum. And we know from time now that if you don't open and explore the duodenum at surgery, you're going to miss disease. So the right surgeon with the right experience is an important distinction. You can see that the theme behind what I'm saying here is once you've made a diagnosis, find an expert, find an area of expertise, because there are lots of little nuances that will give you better care. And here is an example of how the duodenum can vary. This is a patient with multiple endocrine neoplasia, and every single one of these lumps and bumps here is a gastrinoma. So you can cut out this one and this one and this one and this one and leave 2 or 3 behind, and you ain't going to cure that person's Zollinger-Ellison syndrome, and you're not going to prevent progression of that disease. So you need to determine who can you operate on, who can't you operate on, who you're going to help, who you're going to hurt. On the other hand, here's another patient seen in the operating room. The surgeon's fingers are across the duodenum. The scope is sitting in the duodenum, and the light from the duodenum is shining through the wall, and they've switched off all the lights in the operating room, and there's the gastrinoma. This tiny little piddly-diddly 3-millimeter thing was causing unbelievable ulcer disease, pain, strife, and an inability for this patient to actually survive properly. Tiny little thing, easy. A cut and a stitch, and you're done. Right? If you find that patient and you're lucky to get it early enough. Endoscopic ultrasound. It's able to distinguish neuroendocrine tumors and compare the big problem in the pancreas is it a neuroendocrine tumor or is it a pancreatic cancer? And you know, you heard about the Steve Jobs tumor. Now, if you look on the web, he didn't die of neuroendocrine tumors. He died of pancreatic cancer. That's incorrect, right? It's not a pancreatic cancer. It's a pancreatic neuroendocrine tumor. And so in our world, we take offense at putting all tumors and calling them all the same thing. So these neuroendocrine tumors can be distinguished at endoscopic ultrasound, which we do primarily to stage what we think is a far more common disease, pancreatic cancer, put a needle in under guidance, spray some cells onto a slide, and oh, this is a pancreatic neuroendocrine tumor. It's not an adenocarcinoma. The treatment's going to be completely different. So insulinomas are always in the pancreas, and endoscopic ultrasound is very helpful for those that aren't 100% of the time in the pancreas, such as the gastronoma. Here is an example of an endoscopic ultrasound image. This is a live scan, okay? So everything's moving, and the blood is flowing, and the heart is beating, and things are moving around. You really got to know what you're doing here. This is just a static image that things change. Here you see in the body of the pancreas a cyst and a thickened wall to the cyst with a little part protruding in. And this is a cystic neuroendocrine tumor. And I always show the slide because it's not a solid tumor always. Sometimes it's a cystic tumor. So people need to know what they're looking at, and a good endosonographer knows to put a needle into that and to puncture this part of the area and get some cells to see what kind of a cystic tumor is this. Is it an IPMN? Is it a neuroendocrine tumor, etc.? And this, I don't think it's going to play, but we can try. This is an example of an endoscopic ultrasound. I think if you can just click, can you click on one of the images and see if they play? They may or may not. I'm not sure if that's going to work. No, okay. Not serious. Let's go back one. All right, so these are two still images from an endoscopic ultrasound in which you can see the tumor over here and the needle coming in through the wall into the middle of the tumor. And once you put the needle into the tumor, you put suction and you suck cells up, spray them onto a slide, and the cytologist sitting in the endo room, they put some stain on it, they look at it, and you make a diagnosis there and then in the room. And the reason you need to make the diagnosis there and then in the room is if you don't get enough tissue, you don't want to have to bring the patient back and put them through all this trauma again. You do it once until you get enough tissue to make a diagnosis. Small bowels. As I've already mentioned, the last frontier in endoscopy. There's nowhere we cannot go anymore, right? So the video capsule endoscopy is you swallow a camera. Unfortunately, it can't give you biopsy tissue. It can't tell you exactly where the locations are. But now we have deep enteroscopy, and you can see the whole GI tract. I'm going to show you that. So whether we should do this on everybody or not is really controversial at this stage. Because if you've got a classic small bowel neuroendocrine tumor with nodes in the mesentery and 1 or 2 Metz in the liver, you know what you're going to do, right? You're going to tend the patient, take out the primary, do extended the hemicolectomy, get rid of as many of the bulky nodes as you can, look at the liver, try and debulk it. Do you really need an EUS? You know it's going to be found with a good surgeon. So we don't do it in every case, but we certainly do it in specific cases. And here is an example of a capsule, which is kind of, you really need to know what you're doing. This is like 40,000 images that the capsule person sits in the dark room and displays on screens as each picture gets taken. And you know, you can blink and miss the thing, but you can see there's a little bump over here or over here. To me, my untrained eye, I would have just sailed straight by that. But if you're a good video capsule reader, you will pick up these things and say something doesn't fit here. And this is a double balloon endoscope. Am I going too long, Bob? 5-6 minutes I can do. Here's a double balloon endoscope. This is a scope, and it has a tube that goes over the scope and 2 balloons. That's with the balloons together, and this is with the balloons apart. So you slide the scope in, and it goes as far as it can. You slide the overtube in as far as you can. You blow up the balloon. You've now anchored the scope. You push it through the overtube, get it as far as you can, blow up the balloon, let down the other balloon, slide your overtube up, blow up your overtube balloon, let down the other balloon, slide your scope in, and you pleat the bowel. You sort of make the bowel come towards you, and you crawl your way down, and you see the whole GI tract. So that works like this. Here's the double balloon in the stomach. There you've pushed it down as far as you can. You blow up the overtube balloon. You advance it. Oh, you've taken some of my slides out here. They were so nice. Anyway, it shows you this thing marching the whole way down the bowel. Here is the same thing being done from the below. The balloon goes in. You blow up the balloon when it gets stuck. You pass the overtube up. You keep on advancing it along, and you get to see the entire GI tract. So here's some x-rays just to show you that a double balloon from the top can go all the way down, and when you inject dye here, you're seeing colon, so you're all the way down to the large bowel. And here's a retrograde double balloon going all the way up that's now looking back at the duodenum. You can see the whole GI tract. It's very exciting if you're a gastroenterologist. And this is another video that's not going to play. You've got to be a gastroenterologist, right? Anything to take your mind off poop. Okay. Here is a small bowel neuroendocrine tumor. It's small, it's rounded. The wall above it is normal as opposed to here. It looks the same. It doesn't look like it's a tumor of the bowel. It's a tumor under the bowel pushing into the bowel. And there's a carcinoid tumor that you can now, if you've got a double balloon there, you can put a tattoo to tell the surgeon where to go. You can put a biopsy forceps in there to confirm the diagnosis. You can even do a core biopsy and get a KR67. So things have really moved ahead. There are some drawbacks. In the interest of time, I'm not going to bother you. It takes a long time to do a good double balloon. It costs a fortune. Not many places have them. You need to have a very good endoscopist. So you can see I'm a GI doc, but I like to think of myself as the cognitive GI doc. So I do endoscopy and colonoscopy, and I see patients, and I talk to them, and I use some metastatin, and I get octria scans. But I don't do endoscopic ultrasonography. That's another guy. He's an endosonography gastroenterologist. And I don't do double balloons because that's another guy. That's a double balloon endoscopy. So all of this takes very special skills in a very special place. There are other types of enteroscopes, which I think I'm not really going to bore everybody with, but there are other ways to see deep in the bowel. There's a single balloon. There's a spiral enterography. The bottom line is if you want to see the entire GI tract, you really need to do double balloons. Now let's end off a little bit with carcinoids of the colon. So we've done the top, the middle, and the bottom. In the colon, these are often discovered at routine screening, and I get a call once a week. I found a carcinoid, what should I do? Or occasionally, good gastroenterologists who do screening colonoscopy go into the small bowel, at the end of the small bowel, and sometimes say a little ditzel over there. So you can get rectals and you can get terminal ileals found very early. On the other hand, you could find very big tumors in patients as well. Endoscopic ultrasound can also be done in the rectum to stage patients there. I haven't shown you any of those data. And the important point I've already made, that carcinoids are under the mucosa. They're underlying the bowel, and they look different from regular polyps. And if you know what you're looking at, you'd say, that's a funny looking polyp. I'm going to put a tattoo here so we'll see what the biopsy shows. An example over here is of a terminal ileal carcinoid. This is one of my colleagues, David Jaffe, who some of you may actually know here because he was originally in New York City for many years. He's one of our double balloon people at the University of Pennsylvania. And David was doing a regular screening colonoscopy on somebody for just because of the colon cancer risks, not for any other reason. He gets to the cecum. We know he's in the cecum because this is the ileocecal valve. And on the other side, protruding through the valve is this tumor. Oh my God, found the carcinoid. Talk to the patient. Yeah, you know what? I've been getting cramping abdominal pain for all these years. I have about 5 or 6 BMs a day. Lo and behold. Here's a rectal carcinoid found just at the time. And as I said, you can tell they're different. It's centrally umbilicated. It's got the same overlying mucosa as everywhere else. It actually, you can look at this and say, I know this is not a regular polyp. So you inject underneath it. You raise it up off the wall. If it's any larger, you get an EUS as well to see that it's not infiltrating. But this was small enough, came up easily. We know it's not infiltrated and it's not tethered. You put a lasso around it and you cauterize it out. Cured. Done. Don't need to worry about it again. And what happens to me more often than not is exactly they did that, but they didn't know what they were getting. They got a diagnosis of carcinoid and they call me up and say, what are you going to do? And I say, you better go back very quickly before the scar heals, because if you can't find where it was, you've got a problem. But you do go back, you find the lesion, you find the area where the scar is, you inject it again, you put a cap around it, you suck the mucosa back in, you've injected underneath to raise it, and you snare it off, leave a little divot behind, but now we've widely excised this cured. But if you wait 3 months, you don't know where it is, and you can't find it. Last 2 slides. 2 other very important gastroenterological points. As doctors, we hurt patients. We try and help patients, but there are times we hurt patients, and our treatment hurts patients. And many of you are on therapies or have had treatments that have had negative impacts. unnecessarily, because that's the only way we can really advance. But we've got to realize we can make side effects of our treatments. So people who've had pancreatic resections, whether it's a distal pancreas or a Whipple surgery, can get pancreatic insufficiency. You don't make enough pancreatic enzymes to digest your food. You get steatorrhea, malabsorption. We can replace that if we think about it. Dumping syndrome is another problem that patients do see who've had gastric resections, where you can't time the release of gastric contents into the small bowel, and you get a whole lot of flooding after meals and fluid rushing in. You get cramping, diarrhea, and sweating. Dumping syndrome is a problem to deal with. Diabetes, a common problem, anyone who's had the bowel resected. If you lose your spleen, you're at risk for infections. You need to get immunized before your spleen comes out. Octreotide has, or lanreotide, has its other side effects. Gallstones. So whenever we send a neuroendocrine patient for surgery for any reason, if they're in the abdomen, take out the gallbladder. They don't need it. Steatorrhea, which is the inability to absorb fat, is a consequence of the octreotide drying up pancreatic secretions. So sometimes you'll put people on octreotide. You don't want to take the octreotide away because it's good for them. You can add in pancreatic enzyme. Adhesions are a problem with any bowel surgery that can cause obstructions, like the lady who presented that I described. Her bowel obstruction could have been from previous surgeries. And also anybody who's had a terminal ileal resection, so this is the primary extended left hemicolectomy for terminal ileal disease, is B12, bile salts, bacterial overgrowth. Last slide. Multidisciplinary care is essential. So it's very well and important to have a good relationship with your primary doctor, and you need a quarterback. But the quarterback can change. It might be the gastroenterologist initially, and then the oncologist 5 or 10 years later. You need a whole team around you of many different people who are shepherding you through this, because it's a chronic disease. And I tell all my patients we're going to grow old together. Hopefully I'm going to grow older longer, but you never know. It could go either way. So we're all here in this together, and the aim is to convert this to a chronic disease that you can control and maintain for many years. So with that, endoscopy is useful and in many cases essential for the diagnosis of GEP-NETs. There are new imaging techniques which we can now see and sample the entire GI tract. The use of these interventions really does remain to be defined, but I can't stress any more than I have. I'd like to just say it once more time. Multidisciplinary care is the standard here, because we are dealing with a chronic disease with many, many different facets, lots of skills required to look after these patients. Thank you very much for your attention.